Okay, so good morning. My name's Dr. Chad Duplantis, and I'm from Fort Worth, Texas. And so today we're going to talk about digital dentistry and a little bit of a different workflow and maybe an alternative to your practice that will simplify and make your practice workflow a little bit more efficient. So several years ago in 2010, a Dr. Wismayer out of Amsterdam came up with this quote that says, "Digital dentistry is developing to a world where patients and in-mouth products are analog and everything in between becomes digital." I think that he was one of the pioneers of the industry and really realized where this industry was headed. So let's fast forward to today and look at if his quote came to reality. He was talking about the future of dentistry, and if we look, this is a timeline of the digital influx of cases that Glidewell has received since 2013. So over a 5-year frame, you can see that this has grown exponentially, and last month I believe they were close to 20,000 digital impressions that they received in the laboratory. So digital dentistry is growing at an astounding pace. We wonder why it's growing at an astounding pace. Well, it's because we've encountered some problems with traditional impressions. The traditional impressions are all prone to polymerization shrinkage and elastic recoil. And the second component of a traditional impression is the pouring of that traditional impression, and that's prone to problems as well, such as mismatch of die stone to stone expansion. We have problems with die trimming, we have problems with air bubbles, and we have chipped stone and abraded stone when we're handling those models. But furthermore, when we look at stone models and impressions, we think of the lag time and the shipping costs that are incurred from those to go in and out of the laboratory. When I was using traditional impressions, it was taking about 3 weeks for the impressions to return to my office or the product to return to my office. And it was not consistent when I was receiving the product back into the office. With digital dentistry, it's become accurate, it's become reliable, it's become consistent. So the new digital solution includes a wonderful scanner, the iTero element. The second component of that is the software, the fast design software. And the third component is really a very beautiful addition to the system. It's a tabletop mill about the size of a microwave, and it requires two components: 120 volt electrical outlet and distilled water. The majority of the mills on the market require you to bring extra air, extra power into the location for the mill. This one here is truly a plug and play. So it's a beautiful component. But going back, this system allows the dentist to perform a balancing act, which is very easy to do. You have two choices. You can send your cases digitally to a lab, or you can send them to the in-office system. And every case is unique, every case is different, and it's fully driven by the dentist and the patient's needs. So a lot of times I get asked, how do you decide what you're going to send to the lab and what you're going to mill in the office? And it's really a cyclical series of thoughts that I go through when I'm doing that. And there's 4 key components to the cycle. And the first component is the diagnosis. The second is the location. The third is the material choice. And the fourth is time. And once you've evaluated all of these, you decide whether you're going to mill or you're not going to mill, and you're going to send it to the laboratory. So let's break each of these down and let's talk about them in more detail. When we talk about diagnosis, I can't teach a clinician how to diagnose a case, but I can tell a dentist what's best to mill in office and what's best to send to the lab based upon my personal experience. So when you diagnose, you want to look at the clinical presentation of that patient. You want to think along the lines of a patient that may come in with an MO alloy, the tooth is fractured. So you think along the lines of composite being a direct restoration, maybe an inlay or an onlay being an indirect restoration, or a full coverage crown. And you go through that thought process with every single patient. You also have to look at the number of units. If it's more than a single unit, you're probably going to want to send it to the laboratory because it may not be cost effective or time effective to do in the office. When you're looking at that, you also need to think of your prep design. You need to look at the patient's occlusion. What's going to be best for the patient's occlusion in this situation? Their occlusion will also tell you a little bit about their bruxism or parafunctional habits, as well as what the tooth is going to look like after it's prepped, because that plays a big factor into one of the following decision-making factors, which is going to be materials, and we'll talk about that in a minute. But the second factor that I go through is location. And what you want to look at with location is really anterior or posterior. If it's in the anterior, you're probably not going to mill it in your office unless you're a lab tech like Dr. Chi with Glidewell, and you have those skills that you can shade, stain, glaze those teeth appropriately. You also want to look at the condition of the teeth in the vicinity. I always tell people you don't want to park a Cadillac in a parking lot full of Yugos or lesser vehicles. You want to put a nice crown against nice teeth, and you want to put like teeth against like teeth. So if you're putting it next to a PFM, you may decide that for aesthetic reasons you may want to put a PFM there so that everything will look uniform in that patient's mouth. And that also plays into the colors of the teeth in the vicinity. You want to make sure that you have the appropriate colors so that the shade match won't be too far off and it looks awkward in that location. Material. We have several materials to choose from, and we'll break those down in a few minutes as well. But you also want to make sure that you have the correct strength requirements, color requirements, and the shade needed of the particular material that you choose to fit in that particular location of the mouth. If you don't have the shade, then I wouldn't suggest that you choose a shade that's close enough. You want to pick a shade that's going to fit in appropriately in that location. And the final factor, and sometimes it just simply comes down to this, is time. And that's, does the doctor have time and does the patient have time? If there's no time, these cases do take time. If there's no time, or you're fitting this patient in because of a broken tooth, it may be best to send that case to the laboratory. So you want to make a judge of your time and the patient's time, a judgment call on that. But the one thing that I always tell you is you also have to take into account one very important consideration, and that's what the patient wants. There's a large complaint about dentists in the United States telling the patients what they need and not giving the patients what they want or asking the patients what they want. So when you're taking all of these into consideration, keep in the back of your mind and flat out ask the patient what they want. If they come to my office and they want an in-office restoration, I'm going to do everything that I can to give them an in-office same-day restoration. If I can't, I'm going to take the time to educate them as to why I cannot. So moving forward, we've gone through our diagnostic protocol. We've gone through the cyclical events and considerations that we need to take into account. Let's look at materials and what our choices are with this system. There's a fourth material that's not up here, and we'll briefly touch upon that, but there's three materials that we have at our disposal that I use on a daily basis. We have obsidian, which is a glass ceramic. It's actually a lithium silicate restoration. We have Camouflage Now, which is a resin nano hybrid. It's filled with ceramic in a resin matrix. And then we have a very earth-shattering material called Bruxer Now. This is the only mill on the market that can mill a fully sintered zirconia restoration. We have other mills on the market that will mill zirconia in its green state, but fully sintered zirconia is full strength all the time, so it has extra strength requirements, and the mill needs to be more robust in its mechanics so that it can mill this restoration. So the first case we're going to look at is a lithium silicate restoration, the Obsidian Now restoration. Patient came in, tooth wasn't in great shape. When we removed the alloy, I had a decision to make. Do I do an onlay or do I do a full coverage restoration? When I took all the other factors into consideration, we may disagree on this, but I chose to do a full coverage restoration. So we prepped the tooth. Prep design to me is very important. However, for the three materials that I presented, all of my preps, a chamfer is adequate, and I think a chamfer provides the best visualization on a digital impression. So I do all of my preps with a full chamfer. Once you do that, fast forward, since the impression is taken, you send it to the design studio, and then you mill the restoration. Now with a lithium silicate or a glass ceramic restoration, it doesn't come out full strength. It actually comes out less strength. Full strength is about 400 megapascals. So in order to get it to full strength, it has to be crystallized in a crystallization oven. So if you'll notice, there's times on the left side of all these slides. What I would say is for your first few cases, add about 30 minutes to the times that I present, because all of these cases were timed so that we could see how they work in our office for scheduling purposes. So we scan, it takes about 3 minutes. It takes about a minute to process the scan. It takes about 3 minutes to design the restoration. It takes about 12, sometimes 14 minutes to mill. 5 minutes to polish, and 27 minutes to center it in the oven. So once that's done, it's a total of 51 minutes. Send it back to the operatory and seat it in the patient's mouth, which takes about 10 minutes. The whole process took about an hour and 31 minutes. Once again, this is timing for our practice. We all know that we can't schedule in 1 minute increments. So on these type of cases, I'm scheduling an hour and 45 to 2 hours for a lithium silicate restoration. I don't always bank on a very fast time, and I always want to have extra time for case we can't have anesthesia or something takes a little bit longer to polish or a little bit longer to seat. But the patients leave extremely happy. The second case we're going to look at is Camouflage Now. Camouflage Now is a really unique material that Glidewell has taken the time to really research. We've always been concerned with how resin materials are going to bond to the tooth. Glidewell has a very researched and thought out and thorough bonding process that they come out with to make this a very successful material. But Camouflage Now is a restoration that you can kind of fit into a patient's mouth and it'll blend in very nicely. So on this particular patient, the patient came in. You may look at this and say, why are you putting a restoration on this tooth? Well, you can barely see there, but there's an access hole. That tooth had just had endo and there's a crack on the distal of that tooth. So it's a young male. I didn't want to do a subgingival crown preparation, and I didn't need to do a subgingival crown preparation. I wanted a full coverage restoration that would cover as much as that tooth as needed. Not too much, not too little. So we did a full coverage restoration. We left the marginal edge a little bit above the gingiva on the facial aspect. This is how Camouflage Now comes out of the mill. This case comes out in about anywhere from 8 to 12 minutes. It's a very fast milling restoration, and the beauty of it is that there's no firing afterwards. So once it's done, it's done. You place it in the patient's mouth, and I feel very comfortable polishing it in the patient's mouth. So you'll look at this, it's unpolished, it doesn't look that great. However, when we brought it to the patient's mouth, we were able to polish it, blend it in a little bit better, and it's a very nice alternative. Another way that this material fits in very nicely into our practice is for inlays and onlays. That's the majority of what I use it for. But it also fits in very nicely when you have a patient that you think you're going to do a large direct restoration, and the restoration ends up being a little bit too large, and I know that I can make an indirect restoration better and fit it in that patient's mouth, and it's going to take me about as long, and in some cases, it's going to take me less time to mill the restoration and seat it in the patient's mouth. Actual chair time for this case was about an hour and 15 minutes. However, for a Camouflage Now case, I try and tell my staff when I diagnose it and treatment plan it, it's going to be a Camouflage Now case, and tell them exactly how much time to book for that patient. And for these cases, I'm booking an hour and 15 minutes to an hour and a half. And once again, for your first few cases in your office, I'd recommend booking an extra 30 minutes. So about 2 hours for each of these first two cases. In the next case, we're going to talk about Bruxer Now. Now, this is another unique material to have in your office. It's not often that you're going to have an 800 megapascal material that you can use in your office and deliver the same day. So this patient came in, and this is exactly how they presented, and I don't think I had to go fully around the wheel of diagnosis and considerations to realize that this patient needed a crown. And we also, with the patient presenting like this, it would have been hard to make a matrix to fabricate a temporary, so I would have needed a prefabricated temporary. So anyways, we prepped the tooth. On zirconia restorations, they're not necessarily a bonded restoration, so you want to make sure that you have good axial wall height. On this case, we had that, so I felt confident that zirconia would be a good choice in this situation. And also, when you're looking at this patient's teeth, although she's a wonderful lady, we can tell that she's probably not a runway model with these teeth, and she's got a lot of grinding habits that are affecting her occlusion, so I wanted a very strong material for this lady. This is how the restoration comes out of the mill. It takes about 35 minutes to mill, but remember, it takes so long because it's so strong, all right? Now, it takes about 3 to 5 minutes to polish it to look like this. So straight out of the mill, polish it with a few wheels in the laboratory, and then this is the way that it comes out. This is the way that it presented in the patient's mouth, and I felt very confident, and this patient was extremely happy with what we presented her in her mouth. same-day solution, and a very easy solution to offer the patient. So on these cases, remember the milling time is going to take about 35 minutes, sometimes 40 minutes. But also remember your other choice in a situation like this is lithium silicate. It's going to take as long to mill that restoration and then fire that restoration. So don't let the milling time be a deterrent for you. The last material before I get to this that we didn't talk about is biotemps. Now that would have been another alternative to the previous case. If I decided to send that case to the laboratory, remember I had no matrix to make that patient a temporary, so I could have milled that patient a temporary in 6 to 8 minutes, placed it in the patient's mouth. If I were short on time, she needed a restoration that day because the tooth broke. So biotemps is the fourth alternative in the milling solution, and it's a great temporary solution in the office.